So this is, I think, covers most of the poisons. If we see the generalized general category of ones that we come across. What is the therapy that we talk about? I'm sure who has been practicing medicine for some time is not unaware of these terms like gastric decontamination and lavage that we give, emesis, whole bowel irrigations, active charcoal usage, enhanced excretion through alkaline diuresis or diuresis and dialysis is some of the non-specific therapy that we intend to use. So, but with time, the gastric decontamination has fallen out of the view. It was quite famous quite a few years back in movies. We used to see, survive to fight Dalit, Nikala, and patient Jagya. So, unfortunately, the world is not fair and easy like that. It's really indicative, especially if you don't have the ear protector, because high chance of aspiration is there, and you end up with aspiration pneumonia. Needs to be recent, okay, life threatening, less than 1 hour of while accepting a large amount ingestion is one of the indications. We don't use if it's for corrosive poisoning or oil-based poisonings because it's very easily aspirated into the lungs, and then we have another problem at our hands. As I said, unstable or unprotected airways is a big no. And if we know of a therapy which is likely to treat the patient, there's no point in going out with a risky procedure like this. Because aspiration pneumonia and hypoxia, intoxication with a large amount of fluids given for lavage, hypothermia if you give cold fluids, laryngospasm because of the vomiting and all that might occur, or manifestation in the rice tube, injury to the GI tract, and obviously the time spent on the decontamination might be better spent on the other specific therapies. Activity charcoal, because it's optic therapies, is one thing that can be given within the hour if the agent is liable to that, but this has almost the same complication contraindication of the gastric decontamination. Sorry for the typo. It's a whole bowel irrigation. Again, very limited conditions like iron injection of large amount or dilsem or verapamil has been used in life-threatening proportions. People who do drug trafficking with stuffing in the body and packers, or sustained longly acting preparations, lead, arsenic, and lithium bulb. Here are some of the indications, but again, the protected airway has to be. It's contraindicated in these things. There is of perforation, vomiting, instability, aspiration, and definitely the same as for any of these previous two procedures. So this was on the input part. What about we throw the poison out before it does the damage? So in certain poisons, we can give multi doses of activated charcoal and get it out of GI tract. So drugs like carbamazepine, cefepime, dapsone, out through. But again, the contraindication complication part remains the same almost. Urinary alkalization might help in certain drugs which are enhanced. It is enhanced excretion of the urine. Alkaline, must I say, like in moderate to severe PCM poisoning, where dialysis is not yet required, phenobarbital poisoning, herbicides like chlorphenoxes and chlorpromazine supportive care is usually sufficient in these matters, but it can be used. But mind you, if the patient is about to go on dialysis or dialysis indicated, has a limited role. This but can lead to further hypokalemia, can lead to fluid overload or damage the kidney. So we need to be careful without giving large amount of fluids and all to alkalization. So this is, in summary that we see the eyes, we see the mentation, we see the temperature, we see how the lungs are behaving like, the heart is behaving like, what is the blood pressure like, what the bowel sounds like, and what is the skin like. So these are the windows to the body that gives us an idea that in which direction is the deviation. You add up these deviations, look at your toxicology, might reach a diagnosis quicker than any of our lab tests. As I said in the offset, most of cases of poisoning are largely supportive. Okay. Okay. It is important not to waste time in looking for an antidote. If supportive care has to be, run through, you can definitely reach out to poison centers. There's one run by AIMS. I'm not aware of other cities, but you have an AIMS National Poison Center, which you can call at any time and get an idea of what you're dealing with and what to give. But supportive therapy should not be compromised in looking for an antidote, because if by the time you take an antidote, get an antidote, you deliver an antidote, if the other organs have gone into dysfunction, then there's no point. If the patient is hypoxic, no amount of antidote is going to save it. If the patient is in shock, nothing is going to do. So, supportive therapy, the ABC, the substation FPC, vital organ function preservation, this is the mainstay. Okay, though it seems flamboyant, we tend to learn, okay, antidote, those are people. But antidote definitely at the earliest will help, but not in isolation. You have to look at it in totality. Take care of the neurological status. Patient is in coma, having seizure, the brain is fried. Do the antidote. Okay. Hypertension, arrhythmias, hypoxias, renal dysfunctions, acid-base balance. All this has to be taken care of while you look for that, not after you get it. So as I said, everything is a poison. There is poison in everything. Only dose makes a thing of the poison. Father of toxicology. Thank you.